Hi, my name is Alice and I'm one of the members of the evaluation team working on the expanded EMCH evaluation at the Murdoch Children's Research Institute. Outside of that, for the past few years, I've also been studying the Master of Public Health degree at the University of Melbourne. This year, in my final year of the master's degree, I got the opportunity to conduct a student research project on EMCH nurses' use of telehealth during the pandemic. Today I'll be presenting you the findings. Apologies I could not be there in person, but thank you Marcia and Helen for sharing this presentation on my behalf. Before I begin, I would like to acknowledge the traditional owners of the land in which I stand, the people of the Kulin Nation, and pay my respects to their elders past, present and emerging. I'd also like to acknowledge the help and support of my supervision team, the other members of the evaluation team, and our colleagues at DHHS and MAV. But the biggest thank you of all goes out to the EMCH nurses who participated in the evaluation activities, without whom none of this research would be possible. Now, I didn't originally set out to explore virtual health or telehealth implementation for this master's project. But as we all know, the pandemic has pushed health services to work in many new and sometimes uncomfortable ways. But this has presented such a unique opportunity for exploration. My research question was, what barriers and enablers have regional enhanced maternal and child health nurses experienced in implementing a virtual model of care during the pandemic? As I progressed through this research, I realised I also needed to understand what the implementation of that telehealth or virtual model looked like, because mapping this model is something that is key to the utility of this research. It helps contribute to our understanding of which elements of the virtual model could be replicated or adjusted to support its feasibility beyond the height of the pandemic. But why is all this important? Why do we care about using telehealth beyond the pandemic? To answer that, we just need to backtrack a bit. If we think back to before the pandemic stepped into the public health arena, issues with access to health services was a key contributor to the health disparities that exist between rural communities and their urban counterparts. International literature demonstrates that delivering health services via telehealth can alleviate some of these service access barriers. We know telehealth works, yet implementation in Australian rural communities is poor. And that's because telehealth implementation has its own barriers. To better understand what we already knew about these barriers and enablers to delivering telehealth, I conducted a rapid review of the literature. My findings were related to 6 key themes as shown here. Not surprisingly, there were more barriers than enablers, most of which were highly subjective and context dependent. The context-dependent nature presented an issue as most findings related broadly to allied health practitioners across rural Australia, with gaps related to the family health setting, and in particular for vulnerable families. So that's where my research comes in. Here's an overview of my research design, which I won't go into in detail, other than the fact that I conducted interviews with 7 nurses across 4 regional LGAs, and then carried out qualitative analysis on this data. I do want to flag though that there are generalisability limitations due to the small sample size, which was all nurses. As you're all well aware, the EMCH workforce, while predominantly nurses, does also include other allied health practitioners who may have differing views to this sample. Also, this research does not capture the views of families directly, who, as you know, are the primary users of the EMCH service. But as you guys work together so closely, you tend to have a pretty good sense of the family perspective. My research generated some really interesting findings. The barriers and enablers to telehealth use encompass 3 key domains: access to and use of technology, technology skills, and attitudes towards using telehealth, which all showed up in the literature, so there weren't any surprises there. But what I found most interesting was how nurse attitudes could be both a barrier and an enabler. On one end, the learning mindset shown by many nurses enabled their use of new telehealth technology. So I've got a quote here, which I'll just read out. "I'm really proud of myself, coming from the world of BC. before computers, and having to be self-taught in so many areas. So I can't put together an Excel sheet, but there's plenty of other things I can do in this sphere. I think a lot of it has been flying by the seat of our pants and making it up as we go along. On the other end, the attitude that face-to-face is superior to virtual care was a barrier noted by all participants. The thing is with Zoom and MS Teams, you're still doing a bit of observation and stuff, but I would probably, depending on the family, if you're looking at the enhanced environment, I think I'd do a face-to-face because it's that engagement. It's really important, that social contact with a lot of these families because they feel isolated enough as it is. I think this barrier is pretty important, particularly for the vulnerable cohort that EMCH engages, which we will explore more in a minute. Based on my research, I put together a depiction of the benefits and drawbacks at various stages of the virtual model of care as opposed to the traditional face-to-face model. Benefits included faster and easier connections with referral agencies and other EMCH team members, which made for a smoother program entry phase. Going virtual in the clinical management phase resulted in savings of time, travel and money for nurses and families. Now, this is the best part, I think, and I'm just going to switch over to another slide so you can see it better. Telehealth introduced a unique opportunity to coordinate with multiple stakeholders across multiple spread out locations, which is pertinent to the regional Victorian setting. So I have two examples here. Nurses described using telehealth to link families in with specialist allied health practitioners during co-consultations. This is really exciting because these families normally wouldn't have such easy access to these specialists as they're often located in Melbourne or other faraway towns. Nurses also described using telehealth during the transition of care phase. It appeared that telehealth enabled for the first time an opportunity for a joint transition meeting between the family, the EMCH nurse and the universal nurse. Now onto the drawbacks. It's important to note that some of these are unique to circumstances created by the pandemic rather than any integral part of the virtual model. These were mainly related to pressures on the service system due to other health agencies not seeing families face-to-face or having limited service provision, which I'm sure you are all well aware of. So I just want to draw your attention to the drawbacks in the consultation phase, which again, I'll blow up. And for some reason, oh, there we go. Here we have things like increased likelihood of missing environmental cues and warning signs. So I just want to highlight this with a quote, which again I'll read out. Because of the current situation, we had been doing phone calls. We hadn't actually met the mother or been to the home or met the husband. So a few weeks ago, before she birthed, we thought we have to go and meet her face to face and go to the home. And honestly, it was just shocking. There was no way that house was livable. There was no way they could take the child there. And then we further discovered that the partner had a massive family violence record. We could have picked that up a lot earlier. I think this sums up situations where you really can't use telehealth. Regardless, I think this model shows that there are almost an equal number of benefits to telehealth than there are drawbacks. I hope that now you're getting a good sense that these feed in at different parts of the model of care. So now I want to show you how all this resonated with me. My findings suggest that a hybrid model of virtual and face-to-face care may be most feasible in the EMCH setting. Based on the interview data, I've put together a depiction of the potential hybrid model of care. Now, obviously, this model will look different depending on where you're situated and the various barriers and enablers that play in for you at your site. I know many of you are keen to fully return to face-to-face visits, but I hope this model shows you that it's possible to retain the parts of telehealth that worked well for you at your site. For some of you, this may be about connecting with referral agencies or providing phone options for families in between home visits, or using video conference for care team meetings or co-consultations. I think it's clear that pursuing parts of telehealth beyond the pandemic could have great benefits, but before doing so, it's important to address the underlying barriers. This figure shows the barriers to telehealth and where they apply. The barriers are depicted by the black minus sign, and potential ways to overcome them are depicted by the blue cogs. Now, there's clearly a big elephant in the room with the internet connectivity barrier sitting at the centre of it all. Unfortunately, I don't think there's an easy way to overcome this issue in regional Victoria due to its political nature, but I do want to draw your attention to a few other suggestions. As mentioned, the attitude that face-to-face care is superior was a key barrier and not without sound justification. However, there is literature to suggest that with flexible service design, telehealth could be adapted for individual clients, including those who are highly vulnerable. We know telehealth doesn't work in all situations, but maybe what's needed here is more support in how to identify the situations where it works well, and then how to work with those vulnerable clients remotely. Now, something I didn't mention earlier was the sheer multitude of applications which presented a barrier. These are all being used in various degrees throughout the family services sector and included apps like telehealth, Health Direct, Microsoft Teams, Skype, Starleaf, Zoom, Jitsi, WhatsApp, FaceTime, and phone calls. Not surprisingly, this caused confusion and stress for nurses and families. A way forward may be to promote cohesion across the family services sector to use a limited number of platforms, enough to allow for flexibility and family preferences, but few enough to alleviate this as a barrier. Serendipitously, it may also help alleviate other barriers such as lack of access to applications experienced by both families and nurses. This research shows that retaining parts of the virtual model beyond the pandemic could have great benefits, such as online meetings with multiple stakeholders, improving families' access to coordinated and specialist care. There are also savings on the costs and time associated with nurses having to travel thousands of kilometres each week, or families having to drive to the nearest clinic. These virtual methods are best suited for parts of the model of care, such as intake, referrals, and co-consultation. However, during the consultation phase for this vulnerable cohort, it is critical to see for the nurse to physically see the home environment at some point. Despite this research being conducted in regional Victoria, some of these findings could be applied to metropolitan areas as well. Today I've shown you that a hybrid model of virtual and face-to-face care may be most feasible to sustain an EMCH beyond the pandemic. I've shown that there are still important barriers to overcome before it's possible to optimise the virtual care component. Some of these can be overcome by providing adequate IT support, access to telehealth applications, equipment and devices, and training and working with vulnerable families remotely. So that's everything I have to share with you today. I encourage you to reach out if you have any questions at all. So those are my contact details there. Otherwise, thank you for your time.